Hello everyone. Hello sir. Welcome you
Yes, sir.
all to our second online session of this year. For today's session, we have our resource person, Dr. Karthikeyan sir, who is a renowned physiotherapist at Nuhans, Bangalore. Also, continuously, he is sharing knowledge with us as an online teaching faculty at Movement Maestro Academy from more than 1 year. Our topic for today's session is recent trends on stroke rehabilitation. So, without wasting our time, over to you, sir.
Yes, sir. Thank you so much for introduction about myself. My name is Dr. Karthikeyan. Currently, I am working as a clinician cum researcher at NIMANS Bangalore. My topic name is the recent trend of stroke rehabilitation. So what I have deal with the therapeutic application, just I wanted to share my knowledge, experience with my friends and colleagues. So the Movement Maestro Academy given the opportunity to deliver this particular topic because the NIMANS one of the premier institute which we used to deal with all sort of stroke management. The stroke management which consists of, there are two types of stroke. So the first one is, my presentation is introduction. The stroke means it is a sudden deficit for more than 24 hours duration. The term refers to stroke. The first one is TIA. Everybody must be here about TIA, transient ischemic attack. Another one is reverse ischemic neurological deficit. If the incident within 24, that is also called CVA. Within 24 hours, the term refers to CVA. More than 24 hours, reverse ischemic neurological deficit. First, I am going to describe about introduction. It is a non-traumatic brain injury which occur or ruptures cerebral blood vessel, result sudden neurological deficit characterized by loss of motor function, altered sensation, cognitive or language impairment. There are two types of incident which occur in the brain. This is also called as brain attack. Stroke also called as brain attack. That is ischemic stroke. That means vascular, the blood vessels occlusion. There is a clot which used to find out through MRI or CT scan. Then another incident is hemorrhagic stroke. That is a bleeding of the blood which come out from the blood vessels. That is called hemorrhagic stroke. Ischemic stroke, which is the ischemic stroke which is handled by neurologist. Hemorrhagic stroke, there is a neuro intervention approach which will help, especially neurosurgeon, help to restore the hemorrhagic stroke. So you can identify the resultant neurological deficit generally refer to impairment which may or may not result in functional limitation, often characterized or disability. The next stroke, what are all the after post stroke? What are all the symptoms? Immediately or after 1 week, mainly they lose the coordination, they lose the bladder and bowel control, they used to trouble walking, the muscle become fatigue, unable to grasp the object, inability to maintain the balance. This is the post stroke after 1 week. These are all the common symptoms which we used to see in the stroke victims or stroke subjects. So immediately the stroke person used to get the main symptom of headache, vomiting, dizziness, apoplectic fits. There was a changes. They are unable to sit from the floor to stand up. They are unable to walk. They are unable to do their routine work. And another, there is a weakness in the face, followed by there is a, if it is the incident happened in the right side of the brain, the left side of the body will get affected, especially one side half of the body, paralysis. That is called hemiparesis. If the right side involved, left side will be paralyzed. If left side involved, right side become paralyzed. That is called hemiparesis. The shoulder should be flexed, elbow flexed, wrist flexed. All the lower extremity will become the extension position. The flexor thrust occur in the upper extremity, extensor thrust which occur in the lower extremity. The next slide about the presentation. What is the objective and goal of this recent trend of stroke rehabilitation? To achieve maximum level of functional independence, to facilitate neurological recovery, to minimize disability, to successfully reintegrate back into home, family, and community, to re-establish a meaningful and gratifying life. Another, this is a specific, the general goals to exercise and other treatment to facilitate recovery and reduce impairment, to functional training to compensate for residual impairment, to use assistive devices such as braces, wheelchair to substitute for loss of function. This is the objective of the presentation. The types of stroke which I'm going to describe. One is ischemic stroke, another one is hemorrhagic stroke, the third one is transient ischemic attack. The ischemic stroke means there is the blood vessels become the narrowed or fat deposit in the blood vessels or clot occur in the passage of the blood vessels. The blood vessels, if it is blasted, then that is called as hemorrhagic stroke. Then the main symptoms, each one should know. Generally, we call it as fast. Now, the recent the stroke information booklet, which they have identified, that is called be fast. They lose the balance. Their eye will get trouble to see some of the objective. Then face become drooping. The arm should be weakness. Sometimes the speech may be lost. They have to reach 9 to 11 minutes. If they reached, the hospital should have CT scan MRI to identify whether the stroke happened or not. Those facilities hospital only patient has to go and take the treatment. And acute stroke management. So in NIMANS, we consist of, once the stroke happened, the NIMANS, how we are managing. We divide the treatment care into critical care and non-critical care. If the symptom happen, immediately you rush to the any neurologist. First, you have to identify whether you have the stroke or not. So immediately, if they are coming to NIMANS or nearby any neurologist, the critical care management will play key role to manage, to minimize the symptom and maximizing the function. So what we can do in NIMANS, once they reach it, they will identify, then further management, they will go for ask them to take the CT scan or MRI to identify the clot level, whether the stroke happened or not. Finally, if they happen, the medical management will take care, followed by the patients will go to stroke ICU for further management. For further management, once the patient get recovery, then he need some of the rehabilitation management. The rehabilitation management, it is a comprehensive care, which consists of physical medicine and rehabilitation, neurologist, physiotherapist, occupational therapist, orthotist, psychiatrist, psychiatrist social worker, then psychologist. There is a team they used to give the to manage the stroke victims. So generally there are one is neurologist, psychiatrist, physical medicine and rehabilitation expertise, physiotherapist, occupational therapist, orthotist, psychiatrist, psychiatrist social worker, and speech pathologist. This entire team will sit, they will deliver according to the patient need, whatever the, if motor impairment, then the physiotherapist will take care. Bowel and bladder management and spasticity, which is taken care of physiatrist. Some the brain dysfunction, which is taken care of neurologist. The radiologist also to identify where is the lesion, which artery is involved, the clot level, how is it. So neuroradiologist also will play, especially for diagnostic tool. Now the next slide, the prevention. How to prevent? Generally, they have smoking, over smoking, dietary modification, use of specific medication for stroke prevention, antiplatelet medications like aspirin, clopidogrel, dipyromodal. These are all the drugs which will help to manage the stroke victims. Then this is the DVT. DVT, which is managed through some of the therapeutic care as well as they can manage. So DVT, which is managed through some of the intermittent pneumatic compression, then continuous intermittent pneumatic compression, then figure of 8 through they can manage. Then skin breakdown, frequent turning of the patient to prevent the contracture and deformity, which is managed through some of the orthotic appliances. Then mobilization. The mobilization, which will help to improve the motor recovery, especially ask the patient to turn right to left, left to right, then followed by standing, walking, motor recovery, mobilization, time, activity should begin as soon as possible. The recovery from stroke, early recovery, resolution of the post-stroke edema, reperfusion of ischemic pneumonia, reabsorption of local toxins, lateral recovery, collateral sprouting, unmasking, reversibility from diastasis, denervation of supersensitivity. So there is a graphical presentation. This will identify especially how the stroke. When the stroke happened, we divided into 4 categories, which is mild, moderate, severe, very severe. According to the recent evidence, which shows the Copenhagen stroke study, how the graph value, which is mentioned here. The specific stroke impairment and their rehabilitation. Initial examination of patient with an acute stroke include neurological examination. Neurological findings are used by rehabilitation team, especially prognostic factors, development of rehabilitation plan, and selection of appropriate setting for rehabilitation. Reassessment of the patient during rehabilitation provide a means of monitoring progress and subsequently evaluating outcome. The next slide about therapeutic approach to the upper limb, especially flexor thrust, which used to happen post-stroke conditions. So especially which is managed through some of the occupational therapy, they are the expertise, and physical therapy, therapeutic care, which will help to the orthotic appliances. These 3 treatment givers, they used to provide the services, then only it will restore the functions. Especially motor recovery, which is taking care of physical therapist, sensory part, which is taking care of occupational therapist, some of the contracture and deformity, which is taking care of orthotic and prosthetist. So there is a approach, especially physical therapy, being a physiotherapist. So Brown-Strom approach, which will help to minimizing symptom and maximizing especially motor recovery. Bubak, there is another technique, neurodevelopmental technique, which also help to give the strengthening to the upper extremity and lower extremity. Task-oriented approach. So that also will help to improve the gait, balance, and coordination. So Bhubath approach, which is introduced in 1990, it will help to reduce the spasticity and the synergy by using posture and movement in order to facilitate autonomic response that are involved in the movement. Brown-Strom movement, which is introduced in 1970, Emphasize on synergetic pattern of movement developed during recovery from hemiplegia, encounter development of flexor and extensor synergies during early recovery, assuming that synergetic activation of the muscle will result in voluntary movement. Then another technique which is called as PNF, proprioceptive neuromuscular facilitation, which is given by Myers in 1995. Emphasize on using the patient's stronger movement pattern for strengthening the weaker motions. PNF technique are manual stimulation and verbal instruction to induce desired movement pattern and enhance motor function. Another technique which we call as CIMT is one of the most recently developed skill-based technique, especially which is working for neuroplasticity. Based on the theory proposed by Edward Top, use of affected limb can be augmented by forced use by process of restraining the intact limb. The original CIMT 90% of walking plus 6 or more hours therapy, it will be continued 2 weeks. Modified CIMT, constrained induced movement therapy, 5 hours per day, weekly 5 days a week, 3 hours therapy, 3 times a week, 10 weeks it will carried out. Then you can find almost 85 to 90% motor recovery, especially upper extremity and lower extremity, which will help to given by constrained induced movement therapy. Participant must have at least partial wrist and finger extension, have adequate proximal limb control, and have sufficient balance during limb restraint. The therapeutic protocol, especially neuromuscular electrical stimulation. So this electrical stimulation, which will help to prevent the contraction and deformity, to stimulate the particular muscles like biceps, triceps, and the calf muscle, quadriceps, hamstring, which will help to stimulate and it will help to increase the flexibility of the muscles. The muscle activation via neuromuscular electrical stimulation require an intact motor application are well suited for upper motor neuron injury, such as stroke. The therapeutic application have been designed to promote motor recovery, whereas functional application have been designed to provide functional movement during stimulation only. The term neuroprosthesis refer to functional application of neuromuscular electrical stimulation, where the paralyzed limb undergoes stimulation in a coordinated sequence of resulting in functional movement. Robotic therapy. The therapeutic applicator, which is introduced by USA and Western population. In India also, it is coming to help the stroke subjects or stroke victims. Robotic therapy for upper limb have also been developed. The current concept of neuroplasticity, it will help to improve the motor recovery. Robotic therapy greatest advantage could be in capacity, more repetition of upper limb movement with a period of comfort with the therapy based on volitional alone. Robotic device can induce passive or assisted limb movement that is typically directed toward a computer-generated visual target. More advanced creation of robot can provide tactile feedback that kinematically correct users' movement, promoting movement during skill acquisition. Others include mental imagery. Therapeutic approaches of walking, especially body weight support treadmill, balance master. These are all the therapeutic devices which will help to improve the mobility, especially to improve the gait and balance. The standard rehabilitation technique for gait training after stroke overground walking. A very common gait training system is body weight support treadmill training. Superior for gait training to neurodevelopmental technique that use practice of balance and weight bearing before stepping and walking. Advanced iteration of robot can provide tactile feedback that kinetically and kinematically correct the user's movement. Robotic therapy theoretically promote movement during skill acquisition. The next slide. Non. This is a recent advanced technique which is performed by neurologists, non-invasive brain stimulation, that is called transcranial brain stimulation. Delivered passing a strong but brief electrical current, insulated a coil placed on the skull. Current induces a transient magnetic field that flow parallel the skull and generate an electric current in depolarizing neuron. It can be used in two different ways. Diagnostic tool to assess the excitability level of cortical network. Intervention to induce changes in excitability with the ultimate intention of modulating behavior. Direct current stimulation is applied through two surfaces, electrode placed on the skull. Depending on the duration and polarity of stimulation, direct current stimulation can increase or depress the excitability stimulated region. The next one is after 10 days, the post-stroke, they used to develop spasticity, or after 1 month, they develop the spasticity. The physical therapy protocol also, which will help to reduce the spasticity. So before that, what is spasticity? Increase the muscle tone, motor disorder characterized by velocity dependent stretch reflex and can contribute to motor impairment, pain after stroke. Managed with exercise therapy, antispastic medications, baclofen with botulinum toxin, phenol injection, use of static resting splint, especially AFO and WCS, wrist cocker splint, to prevent the contracture and deformity. Intrathecal baclofen delivered by implanted infusion pump provide excellent lower limb spasticity control in patients with the stroke victims. Another one is hemiplegic shoulder pain. Once the post-stroke happened, automatically they used to develop HSP, hemiplegic shoulder pain. It's a common complication after stroke that can inhibit and reduce the quality of life. Prevalence of shoulder pain is the post-stroke hemiplegic, which will be handled through shoulder sling or humeral cuff. These two applications which will help to minimize the pain. Along with we can provide TENS, transcutaneous electrical nerve stimulation, that will help to reduce the pain, especially hemiplegic shoulder. The next, capsulitis. Post-stroke, the victim, they used to develop some kind of reduced range of motion. Then they develop spasticity, impingement problem also they develop. Then CRPS1, reflex sympathetic dystrophy, constellation symptoms, primary inflammatory phase, secondary inflammatory final phase, which consists of this syndrome we divided into primary, secondary, and final phase. So primary, they have the erythema, warmth, and painful shoulder. The secondary, there is skin changes, loss of motion, reduced skin temperature, and occasionally pain reduction. Final phase, CRPS, irreversible skin and muscle atrophy, variable pain, severe loss of range of motion, extensive osteoporosis. So prednisone and exercise, which will help to reduce the pain, especially hemiplegic shoulder pain conditions. More invasive methods such as cervical sympathetic ganglion block, Bayer blocks, and cervical sympathectomy might be warranted in refractory cases. Another one is central post-stroke pain. This is also another type of the pain which is occurring in the central part of the shoulder. Pain described burning, 50%, aching, pricking, lacerating, changes in temperature, touch, movement, or emotion. Pharmacotherapy include amitriptyline, which reduce pain, non-pharmacological approach like TENS, transcutaneous electrical nerve stimulation. Application of pulsed rectangular wave via surface electrode through patient's skin. It will help to reduce the pain and improve the quality of life. The next slide. So these are all the equipment which used to perform especially stroke condition. One is electromyography. The second one is gait rate system. So some of the therapeutic protocol which you have to apply. After that, you wanted to check the gait. There is a system which will identify exactly what is the gait. The gait is, they have the hemiplegic gait or circumdactory gait. Post-stroke, they develop some of the circumdactory gait. So some of the therapeutic application which you applied, we need to quantify your therapeutic application, which is effective or not, especially gait pattern. The gait is a rhythmic alteration of movement in both upper lip and lower lip. The gait consists of, there are two phases. One is swing space and stand space. Swing space, heel strike, foot flat, mid stance. Stand space, which consists of, there are four categories: heel strike, foot flat, mid stance, heel off, toe off, acceleration, mid swing, deceleration. This is the, so when you apply some of the AFO, some strengthening or weight bearing activities or balance training, you wanted to quantify whether the gait is improved or not. This will help to quantify exactly post your therapeutic exercise protocol, which is improve the gait or not. You can quantify especially heel strike, cadence, and straight length, step length. How much changes is that you can quantify through these devices, which will help to identify the gait pattern. Another one is balance master. There is a system which consists of the patient used to stand on the system. There is a plate. The plate, you can put a force on that plate. There is a challenging task will be there. So you need to play that challenging task. Then it will enhance your balance, which will improve the balance of the hemiplegic patients or stroke victims. Some of the orthopedics, so especially solid AFO. Solid AFO, then AFO means ankle foot orthosis, which will help to reduce the contraction and deformity, especially ankle joint. So conclusion, I wanted to conclude the specific approach like physical medicine rehabilitation, neurological care, surgical care, psychiatry care, along with the physiotherapy, occupational therapy, orthotic, prosthetic, psychology, social work, speech and audiology. These entire the things which will help to make the patient, to reintegrate the patient into community, and it will help to minimizing symptom and maximizing function of the stroke victims. So, so the new evidence, application of physical exercise and newer modality as well as pharmacology, surgery, cortical brain stimulation, robotic is now under clinical investigation. So these new devices which will help the patient, especially upper extremity, they have the flexor thrust, if they have lower extremity extensor thrust, some of the device which will help to improve the motor function, especially lying to rolling, side rolling, right side, left side, then sitting to standing, then forward walking. Some of the what do you call timed up and go, the research outcome. You wanted to quantify, especially mobility part, the timed up and go on scale, which will help to identify how much the gait is improved. So that will help to exactly quantify the therapeutic effectiveness. The second one is balance, Berg balance scale. So this scale also, which will help to identify post-stroke, how the balance and your therapeutic intervention, how it will be improved through Berg balance scale, which will help to identify the therapeutic effectiveness. So thank you so much. for given the opportunity to share my knowledge and experience, especially the stroke victims, how to manage, especially rehabilitation will play key role to improve the quality, and they make the patient to reintegrate into community. This will help especially stroke subjects. This therapeutic treatment applications or treatment protocol, which will help to improve the overall quality, livelihood of the patients. Thanks for giving the opportunity. The MMA Academy given the opportunity to share my knowledge experience with how to manage in the stroke subject or stroke victims.
Thank you, sir. You can turn off the
Yes,
slide share, sir.
yes, sir.
Thank you, sir. Thank you so
Yes,
much
sir.
for sharing
Yes,
your
thank you.
valuable time and knowledge as well. Hope this priceless knowledge will help our students and professionals
Sure, sure.
to in their practice and everything. Thank you all the participants for joining, and thank you, sir, again. See you all
Yes, sir.
in next upcoming session. Stay connected with
Sure.
Movement Maestro Academy and keep learning. Thank you so much.
Yes, sir. Thank you so much. Thank you. Bye-bye.